Yes. Uh, I wish I had.
Those are fake patients, which is really
Pardon
weird.
me. Yeah, it's fake name, fake MRN. Uh, I was hoping I would get the whole. Let me. A lady who's 82-ish years old, and they were working up the liver abnormality, which I'll tell you on CT it looked just like a non-cystic soft tissue lesion, uh, sort of in hepatic segment 4A. And so here's T1 uh, with fat sat. It's a little blurred by motion because she's not breathing real great, but it doesn't really look like much. This over here is a cyst. And then here's another T1 without the fat sat on. Kind of just look like a gray blob. And then here's the out of phase. One of the things in the differential for these is maybe you're looking at focal steatosis, but it really didn't drop enough on this to be that. And then here's a T2, and the cysts are easy to see. This thing's kind of hard to see, but it's there. It's like T2, slightly bright. And then here's pre-contrast T1. I kind of showed you that like that already. So there it is, pre-contrast. And then post-contrast early, it does not enhance. One of the things the differential probably be FNH, but the FNHs tend to enhance a little bit more convincingly on that arterial phase. This one doesn't. And then I'll skip the venous phase, the early venous phase, and go to here we are at sort of 90 seconds. And we're starting to get some enhancement in this thing, kind of late and slow. So it was imaged twice by MRI. This was the later one, which was late October. I think the earlier one was like July, and it really didn't do anything between these. So this was a case that was in the conference I just came from with the GI folks, and I said, they weren't happy with this. I said, it's an indeterminate liver lesion by MRI. And I said, it's got late enhancement, which there's some bad things that can do that, like cholangiocarcinoma, but it's not growing very fast. It's growing rather indolently. I didn't show you the diffusion weighted imaging. It's not very impressive on the high B value here, B600. And I said, all we can do is categorize these as indeterminate and worrisome, or indeterminate and not so worrisome, but we always pretty much would prefer these things to be biopsied. And so that was my recommendation here, is even though it was indeterminate, and because it didn't grow, because it didn't have restricted diffusion, it was a little less worrisome, but that wasn't a complete assurance that it was benign. In the same conference, we had another case where it was a larger lesion in a patient with a cancer history, a more heterogeneous appearing lesion, both on pre-contrast and post-contrast images. And so it was kind of a compare and contrast, with this one being indeterminate, tilted a little bit more towards maybe something that's not so malignant, whereas the other one was tilted a little bit more towards something that was indeterminate but worrisome for malignancy. I don't have a biopsy on either one, but that was my recommendation for both.
Steve, I have a suggestion. It could also be a sclerosed hemangioma.
That's one of the benign things that it could be. Yes.
Yeah, and the little T2 vagueness and the fill-in is decent for it, and even the geographic shape, like it's kind of a little rectangular, triangular.
It's elongated thing, like an old.
I actually think they're more common than we claim them to be. We have a whole bunch of like biopsy proven ones now, and when I started looking into it, I mean, there's like 7,000 patients a year that have cholangio. So it's actually pretty rare, even though we see a lot of them because we're like, working them up. And then like about 10% of patients have hemangiomas. So that's like 32 million hemangiomas and like 7,000 cholangios. So I think that like, even if it's rare for hemangioma to die, it's actually much more common than we think it is. So I think this could be, especially if the patient has no primary malignancy and no background liver disease, I think it could be that.
That's an excellent point, and I think you've shown at least one of those in this forum before.
Yeah, it's my favorite thing that I'm trying to put from increase awareness about.
We should try to make a case series on them or something.
Yeah, no, that's my next step. Yep.
When you show that case, Steve, it made me think about Victoria's case from last month. Remember that, like, they called atypical hemangioma? And
Yeah.
then multiple follow-up, it turned out to be cholangio. It was like, yeah.
Right. That's why you have in the back of your mind, you don't want to miss the cholangio, even a low-grade cholangio that's kind of indolent behaving. Although that's uncommon. I mean, we don't like, that's exactly what I told the people when I was sitting there. I said, I don't expect this to return malignant tissue. I'd be surprised, but better safe than sorry. And that's why even Artie, as she said, has pursued many of these with biopsy before. And we're kind of stuck doing that a lot of the time, even though, it doesn't look too scary. Did I don't recall, Artie, if the ones that you showed before were not very T2 bright anymore when they were sort of
so actually I just showed some of those at RSNA, but basically one of the patterns is that one, they lose their T2 brightness, but another feature is some of them can become like really, really T2 dark. And that's pretty unusual for a malignant tumor. And so if you see that, then I bring it up even more that this could be a sclerosis, because it's a combination of fibrosis and some will have like little cystic spaces left, like little.
Maybe it has some trapped blood products or something in there, right? Trapped old blood products
like
heme
and fibrosis. And so the T2 dark areas tend to kind of like not have that nodular enhancement, but so you can have a combination. So it can be on the way. It can be sclerosing, and then you can have a fully sclerosed one that's just fibrosis.
All right. I did not have an alternative